2:30 or 1:30 to 2?
And with dates and kind of what to look for and kind of what the future holds for that. So he's going to present some information on the vaccination, and Tim, I'll kind of just let you take it over. And
sure. Let me share some data here. So, and you may have seen this before. CDC originally was looking at 4 phases of vaccination with COVID vaccine, and now it's kind of been whittled down to 3. And in all actuality, it's probably 2. But early on, they're anticipating we're going to have a small amount of dose of vaccine available, probably under an emergency use authorization, which will dictate who we can give the vaccine to and under what circumstances. And then as we move through that initial target population for phase 1, and phase 1 might be in 2 phases. It might be a phase 1A and a phase 1B, depending on the amount of doses available. And then the anticipation is while we're seeking FDA approval and vaccinating under emergency use authorization, the vaccine companies are still producing vaccine and storing it in anticipation of FDA approval. And once that happens, the door will open up, and all the vaccines that they have produced up to that point will be available. At that point in time, we'll move from a limited situation of vaccination to a more widespread vaccination services using every possible vaccinator we can lay our hands on to give vaccines, probably having some public events as well to vaccinate. And then as we move through that, eventually we're going to get to the point where we're going to have more vaccine than demand. And then we'll probably get to the point where we're in a more of a routine strategy for vaccination, stand down some of the public events, but we're still going to want to maintain a pretty large group of people vaccinating. And then so the first phase is there's some target populations that are being talked about, and that's on the next slide here. So CDC told us a plan for these populations in phase 1. Healthcare personnel, other essential workers, which really hasn't been fully defined. It's looking at possibly, law enforcement, fire services, emergency medical services, probably some critical food infrastructure, probably some critical transportation infrastructure, possibly utilities, as well as some other government employees would be on that list as well. But that list is yet to be completely defined. Long-term care residents and staff, persons with underlying medical conditions, persons that are 65 and older, persons from racial and ethnic minority groups, people from tribal communities, persons incarcerated, homeless shelters, colleges and universities, people living and working in other congregate settings, rural communities, persons with disabilities, and the underinsured persons as well. These populations were chosen for a few reasons. At the federal level, one, for healthcare personnel, obviously for keeping people healthy, and hospital services will still be needed and things like that as we move through the pandemic. But others are chosen based on the possibility of transmission, such as in congregate settings or in the prisons or in homeless shelters, where there's a high risk of transmission of COVID disease. And then people with medical conditions and older people who may have waning immune systems, and people with disabilities that may have waning immune systems as well. And then racial and ethnic minority groups and tribal communities have been hit pretty hard with COVID, so they're on that first phase as well. Kind of a little information about how the tribal way is going to work. They've been given the option of either receiving their vaccine through the feds to the IHS facility on the reservation, or receive an allocation of vaccine from the state. So they have two choices, and the state may have several tribes choose one and some choose the other. That's still yet to be decided. I believe they're going to be surveyed here in the next week or so by Operation Warp Speed, and then they will let us know those decisions. So more to come on that. A little more information on pharmacies and how that's going to work. They're working directly with over 200 retail chains that are have over chains that have over 200 stores in the United States, and then they would allocate doses directly to the pharmacy or to the pharmacy chain's depot, and then they would let us know at the state level, who's getting the vaccine, where it went, and how many doses they gave, and then they would also be giving us the data. And retail pharmacies are probably going to be important early on for long-term care. They're going to work specifically with two national pharmacies to vaccinate residents in long-term care facilities. They have not announced what two pharmacy chains that is. I think that is expected to happen today, probably sometime in the next hour or so. We actually have a phone call here at 2:30 to talk about that. One of the first vaccines to come out is the Pfizer messenger RNA vaccine. Will probably be one of the first that we'll get. It has unusual storage conditions, minus 70 degrees Celsius, which makes for some interesting planning. And then the minimum order of that vaccine is going to be 1,000 doses. So, how we're planning early on, before we get to retail pharmacies, because they will not probably get vaccine during phase 1, because it's going to be the ultra low cold storage. But we're going to work directly with our hospital systems, the Sanford, Monument, Navarra, and then some of the independent facilities like possibly Prairie Lakes in Watertown, and maybe Brookings Health System, and maybe a couple others, to provide that phase 1 vaccinators, where we would send them the vaccine to their pharmacies. They would set up vaccination services in the areas they serve, and possibly in areas that they're not at either, to vaccinate the target population as defined by the federal government and as defined by the state. So they may be working with long-term care facilities. They may be working for people with disabilities. They may be vaccinating congregate settings. So we're still working on a contract with them. I think we have the draft done today, and hopefully by the end of the week, we'll have a little more clarity what that's going to look like, and how it's going to operate when they start getting the vaccine. This is very similar to what happened during H1N1. We really relied on the systems to do the heavy lifting of vaccinating our target population when we had limited supplies of vaccine. And then once we got more doses, we got to more general vaccination services in all the clinics. But early on, Vera Sanford Monument did the heavy lift and vaccinated several thousand South Dakota citizens that were in those early to be in those early tier groups. So back to the pharmacies. These are the pharmacies on a national level that express interest to the federal government to receive direct allocations of COVID vaccine. And then of those, this is what we have in South Dakota, the ones in yellow, the Safeway, CVS, Health Mart, Hy-Vee, Medicine Shop, Walgreens, and Walmart. So that is what's here in South Dakota. I don't know if one or two of those will be on the early list to vaccinate long-term care residents, but it may be possible. So there's a little more information about long-term care. I'll go quickly through this, but so early on, when there's limited doses, we may just be vaccinating the staff in long-term care facilities, so I'd be part of the healthcare provider recommendation. But as we move through phase 1 and more doses become available, we may be looking at people at higher risk, people 65 and older. And then at that point in time, depending on what vaccine's available, we'd be asking the retail chain pharmacists that will vaccinate long-term care based on their federal contract to start that process. The long-term care facilities themselves have a few options. So if we have a staff-only recommendation, and that's where we're at in phase one, then the staff would just be vaccinated with the healthcare personnel in the community. If we're looking at a staff and resident or just resident recommendation, they can choose between on-site vaccination services by the pharmacy partners that are receiving the direct vaccine from the feds, or if they would rather administer it themselves or go with another provider, then that would have to come through our state allocation. So that's kind of what's going on early on in phase one. I'm not sure how everybody is going to be vaccinated and how much vaccine we'll receive, but that's just a little bit of basic information, and I can provide, you know, a little more information or answer some questions if you would like that. But feel free to ask me anything you want to ask, and I'll answer it if I can. I'll put this map up, just kind of an FYI. This is where a Vera Monument in Sanford, or IHS facilities, and our independent facilities are located. So these are kind of where we anticipate early on that, you know, there would be some good vaccination services. We're hoping to try to find, you know, a spot in every state where nobody would have to go more than 50 miles for vaccination. We have a couple of open areas that we're looking at how we're going to solve that issue, but there's some areas we've got really good coverage. So we've kind of been working through maps and overlaying population base for that phase one group to see where population is in relation to where we have clinics that might be offering phase one vaccination services, and we're trying to, you know, get our hands around, you know, how that's going to look, who's going to vaccinate, how the systems are going to work together, and then areas that we're lacking services that we'll have to either set up a points of dispensing type situation that preparedness has done in the past, or if we have to find a local provider in that area that's not part of these groups to provide that vaccination services. So we're still working through all those pieces. We're right now in the process of enrolling vaccination providers. We sent enrollment information out to the main systems, to our independent systems, to our community health offices, and then to the Community Health Association of Dakota's affiliated clinics as well. And they may be involved in phase one vaccination.
Tim, this is Rich Mulholland in Spearfish. I just had a quick question. Maybe I missed this and you may have already mentioned it. Do they have an approximate date when they're going to roll out the first phase of this vaccine? Yeah,
that's a good question. And we keep hearing as early as November 1, but we've never been given anything concrete. I mean, I think by the end of the year, for sure, we'll probably have some emergency use authorized vaccine. I don't think we'll see a licensed vaccine till sometime in 2021. But I do know they're really trying to push out emergency use vaccine, and the FDA just released information to the vaccine companies, guidance on seeking emergency use authorization for their vaccines. I believe they released that yesterday, how that's going to work and how they need to go about it. The licensure, I heard that the FDA wants to hold back until 2 weeks past the conclusion of the phase 3 trials with each individual vaccine. They want to wait two months past the last time the second dose is given, just to make sure they're checking everything out and looking for, for adverse events. Adverse events usually happen fairly rapidly after vaccination, but they're kind of they're going to string it out for a couple months to keep an eye on that before they seek FDA approval. And then once FDA approval happens, that's when the Advisory Committee of Immunization Practices will vote on the use of that vaccine in the target populations.
There's a question in the chat.
Okay. So how do you feel the vaccine will work? That I don't really have, a lens into the trials that are going on or how it's working currently. I don't know if it's going to be like the MMR flu vaccine, where it lessens the disease, or it's going to provide, you know, really good protection. The data will come out with this once they seek FDA approval, and probably it's somewhat under emergency use as well. I mean, I anticipate it's probably going to be along the lines of any vaccine that, you know, no vaccine's 100%, and no vaccine's ever been 100% effective, but it's been effective enough to prevent disease, and where, you know, the whole idea about vaccination is get into that herd immunity or community immunity situation where you have enough people vaccinated that the small amount of people who didn't develop an immune response to the vaccination would maybe not be infected because everybody around them has an immune response. So I don't know what that number is, or how far into the population we need to get vaccinated to get to herd immunity. That's probably something we won't know until we're vaccinating for quite a while, how that's going to work out. 1 or 2 doses, good question. So both the Pfizer and the Moderna vaccine, which are the 2 vaccines anticipated to come out first, they're both messenger RNA vaccines. They're both 2 doses. They're not interchangeable. The Pfizer vaccine is 2 doses separated by 21 days. The Moderna vaccine is 2 doses separated by 28 days. There are other vaccines that are in phase 3 trials. Johnson & Johnson has one, and AstraZeneca has one. I don't know how those play out with doses. I've heard anecdotally that the Johnson & Johnson vaccine is a single-dose vaccine, but I don't know that for sure. But the early doses will most likely be 2 doses of vaccine for an immune response.
This is Dan Cross. I just have one question, just to make sure that I heard everything right. So the first phase is really going to be focusing more on probably like long-term care employees and people residing in those types of facilities. Is it the second part of phase 1 where people in more of our types of settings would be eligible for that? Okay.
That's what it looks like. You know, that's really is all dependent on, you know, ACIP that's going to make that final target population determination of how we're going to move forward. But yeah, they're kind of anticipating early on it'll probably be just healthcare workers in phase 1A, and then in phase 1B would be the rest of that group that's on that high risk list.
Okay, thank you.
Yep. Nope, there's no more questions. I really don't have anything else.
Thanks, Tim.
Sure.
Okay, I think we can probably, I know that Dan Cross, you'd sent some questions our way, and I shared those with Jana and Tom. So Jana, I don't know if there are any of those that you can kind of walk us through to address.
Yeah, give me 1 second here. Let me pull those up. Okay, so I can just kind of go through them here. It looks like there were kind of 4 questions that were brought to us, and one was regarding labs, that maybe some agencies are having trouble finding a lab to do the testing. So I would just encourage you to reach out. You can certainly reach out to me and we can facilitate that for you, work with the Department of Health in assisting you in finding a lab that will work in your community for you. But I think that's just going to be on an individual basis, to, you know, based on where you're located. So certainly feel free to reach out to me if you have, if you're having trouble with the lab. And then there's a concern about staffing. And again, I think that's going to be dependent on where you're located and what services are in your community. So again, I would encourage you just kind of to reach out to whatever health system is in your community. And if you're having difficulty, again, you can reach out to myself or to the Department of Health in assisting you in finding somebody, but it's going to be dependent on your community again. The rapid testing, that was provided and paid for by CMS to the long-term care facilities. Our agencies were not at this time getting the rapid testing. My understanding of the rapid testing is that long-term care facilities are using that testing to test their staff when they're coming on duty. So that's kind of what that's used for. But as far as I know at this time, our agencies are not included in that. Okay, and then lastly, there was a question brought forward about some conflicting information on guidance and procedures. And so if you have any conflicting information, you can certainly bring that to my attention, Leah Bohmsberger's attention. I sent out an email this morning with her information, and I've sent it individually to a lot of the agencies. She's really the COVID expert and keeping up to date on all the changing information. So you can certainly reach out to her directly, or you can reach out to me and we can research that for you and get you the most up-to-date information on whatever specifics you might have. And I think that's it.
Jana, there was one question that kind of has two parts, and one of, I think it's the second bullet point on what Dan had sent us. It goes back to that conflicting information, but this one is particularly about sentinel testing. Do we know what kind of communication has gone out to testing locations regarding the why behind the sentinel testing?
Well, the sentinel testing is being completed. There's the 4 labs that the Department of Health has a contract with to provide the test kits and then to run the tests. And so I'm not quite sure, if there's a doctor at a local clinic, there's different guidance for different settings and different individuals. So sentinel testing is specifically related to congregate settings. So, the question was that, let me look here real quick, just a sec. That a doctor may not understand why sentinel testing needs to be completed. I suppose if a doctor wasn't aware of the sentinel testing recommendations from the Department of Health for congregate settings specifically, that, that might be confusing, or they wouldn't know why you wanted to test an asymptomatic person. That kind of makes sense to me. So I would guess that's probably why a doctor might not understand that. I'm not really quite sure what the, not speaking to the doctor directly or not really knowing the background of the situation. I don't really know how to answer that. Besides, I guess it doesn't really surprise me that that would be confusing to test an asymptomatic person if they didn't understand sentinel testing and the recommendations for sentinel testing.
Yeah, if a provider if this is a barrier for a provider in setting up their sentinel testing, be sure to contact us and let us know, and we can work with Department of Health to try to resolve that in some fashion.
Is all the guidance for the healthcare providers coming from the Department of Health, or are local communities free to develop their own guidance about when testing is necessary and when people can come to work and not come to work and that kind of thing? Nobody wants to answer that.
I would just say that, you should have your own policies and procedures in place for your agency, but those policies and procedures should be based on Department of Health and CDC guidance and recommendations. And best practices. Of course, that has changed several times over the pandemic, and just, try to keep up to date with those. But I would just say, follow those recommendations, and that your agency should have policies and procedures related to those recommendations from the CDC and Department of
Seems
Health.
to be, we've just recently, especially, a great deal of variability of what people are expecting and doing, and so it kind of makes you wonder what the heck is going on. For instance, coming to work, even if you've had firsthand exposure, and then even after that, coming to work in a healthcare facility, as long as you're wearing masks and protective equipment, even if you test positive, I had never heard such a silly thing. But till today, so I don't know where that stuff's coming from. That's not coming from the Department of Health, I don't think.
That comes from the Centers for Disease Control, and those recommendations are all easily searchable, and you can see the different recommendations for essential healthcare workers and non-essential healthcare workers there.
So the current CDC recommendation is that we would have people testing positive for COVID and have them coming to work wearing masks and personal equipment, and that would be fine. That's the CDC?
I would encourage you to go to the cdc.gov. They have I'm not going to quote off of memory what the most recent guidance is, but that is where it comes from.
Who is this?
This is Caitlin from the Department of Health.
Okay. Wow.
Right, this is Angela. Can I just add to that? Those guidelines are under the crisis and staffing shortage, and I think they're meant to be for extremes and not the norm. Certainly if somebody is positive and you're dealing with places like New York where they're full of hospital, that's their only staff. The crisis shortage talks on there about if, you have the shortage and you're not able to do without a staff, maybe they're asymptomatic or exposed, but those kind of situations. But I think a positive coming to work would be at the very, very least of you have nobody, I guess. I mean, that's how I look at it.
So Caitlin, just to be clear, these are CDC guidelines / recommendations, and as an employer, I'm assuming that you could stray from those recommendations. If, for example, if you didn't want a positive employee working, that as an employer you could make that call. But
so if you review the guidance that is out there, it's just like Angela was saying, it gives you options for handling different staffing and different crises types of situations. So there is no answer for what you should do. There's only recommendations for what you can do given the situation in your community and in your workplace. So it's absolutely up to the employer, just like Jana said, to develop their policies and procedures with that in mind.
okay.
Any other comments or questions?
Yeah, it's Angela again. So going back to a couple of, so when we talk about the rapid testing, I know Jana and I have had conversations on these before, and I just kind of wanted to put it out there that I think we realize that we're not being considered right now. And I think the key thing is that we're asking to be considered. We're asking to be on the thoughts of how can we get assistance with getting rapid testing. I know personally myself, I've called for months. I've been talking to actual in different places because then we were told, well, we can get a machine, they're like $5,000. And in order to get it free, we have to have a commitment for 3 years based on how many tests we run. Well, we're not typical places that are going to be running tests on strep and influenza and COVID and these kind of things. So, so that right off the bat disqualifies. I mean, I personally applied for, and we have a CLIA license. I mean, we're all set to go, but I think the difficulty is that we're not in a position to get them, even if they are available. And so I think the question is asking for help on how to, we get considered, how does that equipment become an option for us as well for rapid testing?
Caitlin or Jana, do either of you know what some of the parameters are for that? Just off.
So that the distribution of those point of care testings came from the federal government level from CMS, because those facilities have been identified as such a high risk, and not just high risk, but we've seen really poor outcomes in those settings when they have it. So I'm not personally aware of us, or at least myself, having any kind of say-so or impact on how they're distributing that equipment from the federal level. There's something we could advocate for given the opportunity. So it's good to know that you guys have done some of the work to get the CLIA waiver and things like that in place, so that you're poised to receive and use those if they became available. And certainly if we had recognized that, and if we're able to somehow purchase some of those as a state, that would be something we could think about. I don't know if any of that is possible, but it's really good to communicate that desire or that need from you guys.
Yeah, I mean, I think we would, I mean, obviously, in my opinion, for us, I'm not looking to be able to do our sentinel testing with a rapid. I'm really looking for those situations. We've had instances where a person supported is symptomatic, and they're not, and depending on the lab and where things go, they're not at the top of the list, so we had one that took 5 days to get the results back. And actually, and I went out and searched for them. It wasn't like we were notified, and so during that time, you're, utilizing valuable PPE and other things, and it would be nice to be able to shorten some of that when you have some of those high risk situations where you've got somebody who's symptomatic that you're, concerned and wanting that quick test.
Yeah, I see your point with that completely. And so what we can do, or what I can do, is take that information to our executive management and to our people who honestly work the most with like our FEMA allocations and our state stockpile, and find out if there's a way for those to become available. And if they do, that we'd like to consider the community support provider settings as a good placement for those.
Yeah, that would be wonderful. Because I mean, I know they're out there, obviously, because McKesson told me they were. It's just that we need help getting something qualified, or we're not set up like some of those big places to qualify for those free machines, or those kind of things that are out there. And so we're really hoping somebody can help lead the way on that, and reach out and put our name in the hat.
Sure.
I would just echo those comments, Angela, and appreciate the consideration, Caitlin. The populations that we're serving additionally are challenged. So when we have somebody symptomatic waiting for test results, having to have them quarantine is especially challenged given their ability to understand and their lack of patience, frankly, for the whole process. So if they're having to quarantine for 5 days while we're waiting for test results, only to find out that test result was negative, it just makes testing that much more challenging with the populations that we're supporting. So I just wanted to offer that as feedback for consideration as well, and appreciate you taking that forward, Caitlin. If we're able to get those rapid testing devices and tests, be incredibly beneficial to the population.
Well, I will be happy to take that information forward and see if there is, if there are any options available to you guys as a group, and those of us who work with you guys as a provider type as well.
Thanks again for that, Caitlin. We appreciate that.
Of course.
Any other questions or comments? I think we are slightly over time, but want to be cognizant if there are other follow-up or other items to note.
This is Jana, and I'd just like to say that I encourage you guys to reach out to Leah if you have any specific questions or if you need some guidance. I did send an email out that I'll be out tomorrow and Friday. So please, if you have any emergent situations with COVID and you feel like you need point prevalence testing, any recommendations that Leah has for you, we will approve payment for. So please reach out to her, and she's very responsive, and she can help you out, and she knows that I'll be out for the next couple days. So, and that somebody may be reaching out to her. So.
Okay, hearing none. Any additional questions or concerns bringing forward? Just wanted to confirm with Jana's note about reaching out to Leah. Does everybody know how to do that? If needed, yes? Okay, perfect. All right.
Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Bye.